Hello dear students, today I want to provide you a lecture about sexually transmitted diseases in urology. Yeah, of course we will touch some points of gynecological problems related to STDs, but mainly we will pay our concentration on urological problems. Okay, next slide. Yeah, epidemiology of sexually transmitted diseases. So the sexually transmitted diseases are very obscure, so that's why we have so we can detect them mainly in well-developed countries with a very good bureaucracy. So where every case is accounted. Actually I get the data of USA. So which cases, reported cases of chlamydia is approximately 1 in 6 millions patients in a year in 2016 were registered. So it's 500 out of 100,000 of people. So it's from a change from 2015 is a 4.7% increase. And nowadays it's the most common sexually transmitted disease in worldwide, and especially in USA it's confirmed. But in other cases, so we in Kyrgyzstan and other countries, usually these disorders try to be obscured from announcement, from studies, and that's why we can have exact statistics. But as my experience says, as being a neurologist, so yeah, chlamydia is the most common infection. Second one is gonorrhea, and it is very common. So approximately 500,000 in USA, 500,000 of patients in USA. So they had gonorrhea in 2016, and it increases in 18.5% increase. And syphilis. So nowadays syphilis is not so abundant as it was in 19 and beginning of 20th century. So because of antibiotic expansion. But still it's increasing. So 17.6% increase from 2015. So in USA. Okay, that's very worrying symptoms. So that these infections, they have not only danger for urological organs, they affect reproductive function, especially for females and sometimes even in males. So that's why the statistics is very dangerous. This direction of evolving of this is very dangerous for future. Clinical prevention guidance. So how to prevent this infection? So accurate risk assessment, education and counseling of persons at risk and prevention strategies. So persons at risk, they are every person who used to have sex without condom, without contraceptive methods, barrier contraceptives only. Every person who have contacts with more than one person, they have a risk. So pre-exposure vaccination of persons at risk for vaccine preventable STDs. There are nowadays we have only one STD, which is preventable by vaccination. It's a human papilloma virus, and it's very dangerous for females, and you will discuss it in gynecology in the common semester. So then in common year. It causes the risk of cancer of cancer of not uterus, but it's a cervix of uterus. Yeah, cervix of uterus. But other vaccines are not available, as I know. So nowadays, even if they are available, but they are not provided nowadays. Identification of symptomatic or asymptomatic persons infected with STDs. So that's a common slides will be discussed. So how to identify the symptomatic and asymptomatic persons. So which group risk factors we should check out. Effective diagnosis, treatment, counseling, and follow-up of infected persons. So that means when you treat a patient with this disorder, you don't have to just give a treatment and forget about him. You should control the treatment, control the symptoms, and check out is he following your advices. Okay, and evaluation, treatment, and counseling of sex partners of infected persons. Of course, if one person had a STD, you have to worry the other person, so another person, partner about this infection. So because he or she might be already infected too. So and they have to make treatment. So because if you treat only one partner and one partner is healed, but then he returned to the same partner who is obscurely infected, so it leads to reinfection. And doctor mistakenly can think that his treatment doesn't work, but his treatment worked. But a patient has a reinfection from the same partner he had sex with before. Screening recommendations. So, how to screen for this infection? So, routine screening of chlamydia trachomatis. It's an annual basis for all sexually active women younger than 25 years of age. So, sexually active women, so especially, to be fair, we have a lot of prostitutes are present in most countries, and they should be checked up for these infections. And actually, where it's decriminalized prostitution is present, like Netherlands, so they have every week they check for chlamydia in routine way. Routine screening of necessary gonorrhea on an annual basis for all sexually active women younger than 25 years old. Of course, no one do it in most countries, but it's recommendations. It's recommendation of Lefevre. And annual screening for chlamydia trachomatis and necessary gonorrhea in women with risk factors. So, which risk factors we're supposed to talk? So, it's risk factors mainly, active sexual contacts without contraception. Pregnant women. So, as well, all these STDs, they are affecting pregnancy and especially carrying of the baby. So we have to check females in planning pregnancy. We check it before fertilization, and we check not only for chlamydia and necessary gonorrhea. We check it for HIV. We check it for syphilis. So anyway, we check it prenatally. So even before pregnancy, if it's possible, but if pregnancy already occurred, so we check it during the pregnancy. So. Okay. And also, don't forget about hepatitis C, hepatitis B, which are actually also sexually transmitted disease, but it doesn't affect sexual organs and urology organs, so that's why we don't talk about them. Persons in correctional facilities, so women younger than 35 years of age and men younger than 30 years of age in correctional facilities should be screened for chlamydia trachomatis and necessary gonorrhea. And universal screening should be conducted on the basis of local area and institutional prevalence of early infectious syphilis. And so correctional facilities like alcohol users, drug users, so they used to have some uncontrolled and not regular sexual contacts, so that's why they are like risk groups. Men who have sex with men. So also all these infections are way more commonly spreading, especially HIV and hepatitis C. They are way more commonly spreading, not in a casual sex between male and female, but between males and males. Sexual contact is very dangerous for transmission of HIV and hepatitis C. But also along with it we have also the syphilis, chlamydia trachomatis, necessary gonorrhea. So all of them can be transmitted in a gay community. Prevention methods. Prevention method is very easy to explain. It's a male condom and female condom. Might be never seen it, but we have female condoms. Yeah, so that's. Male condoms are very commonly present, so that's a way of wearing the condom we'll discuss in practical classes. So I will show it you on. So we have some simulator, and female condom also situated in a vagina, so it has two special rings by which it fixed in vagina. So, but it's only barrier contraception is available, necessary here, because only barrier can prevent infection. Because other methods of contraception, they avoid only pregnancy, so caps which are used, so cervical caps, or special smears, the spermicide smears, or just calendar method. Yeah, so it's necessary only for prevention of pregnancy, but not prevention of STD, of course. Only barrier contraception is there. And the main symptom which is happening in urology from STDs, it's urethritis. Urethritis, so which symptoms of urethritis you should know? It's a urethral discharge, so sometimes it's more abundant, sometimes less abundant, but it's always present some discharge. In some cases it's obscure, so we're going to discuss it a little later. Dysuria, so due to inflammation of urethra, so normal passage of urine is blocked, so it leads to dysuric symptoms like frequent urination, or also tangent urination, so not complete urination, so when voiding is not completed. So that's dysuric problems, and also especially this dysuria, it makes more severe when urethritis is accompanied by prostatitis. Urethral stringing and itching. So stringing and itching, so that's sensations of, especially in early periods of urethritis, so in first days of inflammation. So it manifestation goes with stinging and itching. Okay. And penile tip irritation, so irritation of penile tip, so also sometimes a symptom, because usually males don't care about itching and stinging there, so maybe they think it's today I didn't wash it, yes, or didn't keep hygiene of penis, so that's why they don't care about it. But when we have penile tip irritation, so it challenges the normal sexual contact, it's painful, it's visible that something is wrong, so that's why they usually come to doctor. Urethritis, as I said in the beginning, so urethritis is often asymptomatic. So sometimes, especially in chlamydial infection and in chronic gonorrhea and in the mycoplasma, so this urethritis might be asymptomatic, and patients think that they are healthy, and that's why they can keep spreading this infection in population. Etiology. So etiology, so mainly we talk about Neisseria gonorrhea, so it's traditionally we name this like a classical type of urethritis. So it's Neisseria gonorrhea, it's gonococcus, or Neisseria gonococcus. So it's diplococcus, so which reminds you by structure of meningococcus. So, but it is very specifically for urethra and female genital system. Non-gonococcal urethritis. So actually we divide all the urethritis in two parts: gonococcal and non-gonococcal urethritis. So the non-gonococcal urethritis usually caused by Chlamydia trachomatis and Mycoplasma genitalium. And somewhere, so in the later part of this lecture, we also added here ureaplasma, urealyticum, sometimes also causing urethritis. Last studies shown that they very rarely causing this, but it's a symptom that patient has a lot of sexual contacts, so with strange persons, yeah. So that's that might be obscure mycoplasma is present there. So that's also, yeah, it's a point of following discussion. And another less common cause is Trichomonas vaginalis, herpes simplex virus, Haemophilus vaginalis, and even adenovirus can be spread there. Yeah. Okay, let's talk about it. So, diagnosis of urethritis can be documented on the basis of any of the following signs or tests. So, when we can write urethritis. So, if a patient has mucoid, mucopurulent, or purulent discharge in examination. So, it doesn't matter if we have, even before routine examination of smear So we have to put the diagnosis of urethritis. Then gram stain of urethral secretions demonstrating greater than or equal to 2 WBCs per oil immersion field. So this measure. So if we have, it's an indicator of inflammation. So that way, if we have more than 2 WBCs, so it's a symptom of inflammation. So we have to delve deeper. So which infection caused it? If we don't see it by casual smear. Positive leukocyte raised from a first void urine. So it's another method of checking of urethral infection. It's a first void urine. So because first void urine will wash out all the urethra, and all leukocytes which are present there, so will be appeared in a sample. So it's very important to explain to patient what to do. So they should avoid only very little portion, not more than 20 milliliters of urine. So first urine, and we can diagnose this. And if we have greater than 10 WBCs in immersion field, so this is also indicator that we have urethritis. This patient. Gonococcal urethritis. Finally, let's talk about gonococcal urethritis. As you see here, Neisseria gonorrhea, gram-negative diplococcus, and it has incubation period of 3 to 14 days. Sometimes less than 3 days. Sometimes first symptoms like irritation, like itching. It may appear even earlier, but usually patients come in after 3. Sometimes even after 14 days. But usually manifestation goes earlier, and patient just extend the time to come to doctor. But usually it's very early. But literature says that it's 3 to 14 days. Symptoms are very abundant. It's urethritis, so same symptoms we discussed before, urethritis. But also complications of gonococcal urethritis are epididymitis, prostatitis, proctitis in case of anal sex, and rarely disseminated gonococcal infection. So very rarely it resembles the septical process. Very rare. Epididymitis, I just remind you, is inflammation of epididymis of testis, so scrotum organ. But let's talk about women a little bit. Women are usually asymptomatic, so discharge is very uncommon, and so it might be with sequela of the diseases, pelvic inflammatory disease, so tubal scarring, infertility, ectopic pregnancy, and chronic pelvic pain. So sometimes females, they don't mention that they have gonorrhea, Neisseria gonorrhea infection, gonococcal infection. So and mainly it's located in the genital system, but not in urinary system. So diagnosis. How to confirm a diagnosis? Of course, it's a gram stain. We have a male urethral specimen, and we can see polymorphonuclear leukocytes as it's shown here. Now with intracellular Neisseria gonorrhea. So they are the intracellular parasites, and they're present inside the leukocytes. So because neutrophils, they trap them, so in a pus. So sometimes these neutrophils will die and cause creating the pus, and this we have abundant discharge. So neutrophils usually trap in this. And low sensitivity of gram stain sometimes doesn't rule out the infection. So sometimes we don't see this infection. We see discharge, but we can't identify the Neisseria gonorrhea. Now that's why more objective method is the NATS, or also named as PCR. Yeah, so polymerase chain reaction. So it's nucleic acid adhesion test. So it is available for the detection of genitourinary gonorrhea. Cultures require urethral swabs. But PCR or NAAT can be performed on first catch urine and urethral swabs. It's not NAT is not cleared by FDA, Food and Drug administration might be in USA. It's a special organ, governmental organ. It's not approved for rectal or pharyngeal and conjunctival infections, and that's why required to perform a culture. Culture is preferred to detect these cases. So yeah, that's a point I have to put it in your mind. So oropharyngeal, conjunctival infection and rectal infection of gonorrhea is also possible. So it doesn't mean that if you didn't so that's why very commonly, I said it in practical classes, but I'll repeat it again. Very commonly patients come into with gonorrhea and they claiming that they never had sex. But when we figure it out, when I ask patients a little deeper, so asking might be he has some oral sexual contact, they say, so oral sexual contact, it's not a sex, yeah, it's just oral sex. No, it's a sex, it's also sex, and that's why if a female or male, doesn't matter, so has a oropharyngeal gonorrhea, so it also can cause the necessary gonorrhea of urethra. So that's why keep it in mind also. And you have to, in consultation of your patients, you should also say that contraception is used not only for genital sex but also for anal and oral sexual contact. This is the best way to save you from infections. Okay. Actually, but usually it's not everywhere is talking about, but Neisseria gonorrhea can obscure the detection of chlamydia trachomatis because of abundant discharge, because of abundant Neisseria gonorrhea production. So that's why sometimes chlamydia trachomatis, which is also present along with it, so it's obscuring. And it's better to perform for every patient with Neisseria gonorrhea, with gonococcal infections, better to check chlamydia trachomatis too. So because they usually come along, so because it's spreading within a special population, so very sexually active males and females, between them it's spreading, so usually in a package. Okay. Treatment, so here are American guidelines, USA guidelines, so it's a little different in our countries. So, but we have to respect this organization, the Center of Disease Control and Prevention. So they give guidelines for many other countries. So for gonococcal infection, be treated with a single dose of both ceftriaxone, 250 milligrams, and azithromycin, 1 gram. So actually, previously it was ceftriaxone 250 milligrams, so alone. But because chlamydia is also very commonly present here, azithromycin is also recommended because azithromycin is more active against chlamydia trachomatis. So that's why I have one dosage of them, so just for prevention. If ceftriaxone is not available, alternative regimens are cefixime, 400 milligrams. In a single dose, also with azithromycin. So it's a common treatment, but we have so if a patient is allergic for ceftriaxone and allergic to cefixime, so then we can choose other treatments. So we have other approaches. So conjugate should be treated with azithromycin 2 grams orally. So azithromycin so is effective against so in high concentrations can be pretty effective against Neisseria gonorrhea. Or might be performed gemifloxacin and gentamicin. So this gemifloxacin is a group of fluoroquinolones, and gentamicin is it's gentamicin raw antibiotics. Okay. Resistance, nowadays resistance is getting very high. So and 25% of isolates were resistant to tetracycline, 19.2 were resistant to ciprofloxacin, and 16.2 were resistant to penicillin. An increasing percentage of isolates demonstrating reduced susceptibility to azithromycin, so only 0.6%, it's not too much, but resistance is still present before. And now, yeah, as I said, it's increased to 2.5%. Then reduced susceptibility to cefixime and triaxone remained low in 2014. It's 0.8 and 0.1 respectively. So that's why ceftriaxone is the best treatment, and cefixime and ceftriaxone, like the same role antibiotics, is the best treatment against the gonorrhea now. All patients who are diagnosed with gonorrhea should be tested for other STDs, as I said, chlamydia, syphilis, and HIV, because obviously this patient in a risk group. So for these disorders, because he has a contact with some patient who also had sex with other people. Yeah, so that's and don't use to use condom. So that's why risk of chlamydia, syphilis, and HIV increases in these patients many times. So yeah, and another point that because of high rates of reinfection, a follow-up test is recommended in 3 to 4 months. So you assess your treatment, you assess your effectivity of treatment after 3 or 4 months. And also, very strictly, you should say to your patient that they shouldn't have any sexual contact. So without condom, only with a condom, or with a constant sexual partner who is not cheating you. Yeah, and 7 days after treatment, so all sex partners have been adequately treated. So because if he treated by himself, so he will have contact with another person and get this infection again. So it's very commonly present, so because life doesn't teach someone. Non-gonococcal urethritis, so mainly it's chlamydia. So as I said before, it's nowadays is the most common cause of urethritis. 15 to 40% of non-gonococcal urethritis cases. Many diagnosed with urethritis will have no definitive diagnosis. So some patients with, who has urethritis remained without diagnosis. And in our country, by protocol, we check for ureaplasma urolithicum and mycoplasma. And treatment against these infections is pretty effective. So that's why I think these guidelines should be revised to our one. The second most common identifiable cause of NGU is Mycoplasma genitalium, is found in 15 to 25% of men with symptomatic non-gonococcal urethritis. So they claim that ureaplasma urolithicum has been weakly associated with non-gonococcal urethritis, specifically among young men with a few sexual partners. And they say it should be, however, considered in men with no other identifiable pathogens. So yeah, and actually we, urologists of Kyrgyzstan, routinely send the patient for 3 main infections. It's 3 main non-gonococcal infections: chlamydia, Mycoplasma genitalium, and also ureaplasma urolithicum. Of course, and other causes are Trichomonas vaginalis. It's identifiable in genital smear, so that's why we can claim the Trichomonas vaginalis. So we don't have to make a specific test, PCR test against for NAT test for Trichomonas vaginalis, because it's identifiable just by microscopy. So also we will discuss it in details. And other causes so might include the herpes simplex virus and adenovirus, especially HCV1 and HCV2. So they're genital herpes. So it's not the same herpes which caused lichen, yeah, or MIB, which causes a herpes infection or herpes throat infection. They are different viruses. They are very specific for genital region. So chlamydia. Chlamydia, so it has same incubation period, 3 to 14 days. So in USA it's the most frequent case of urethritis. So sequela, so like complication of this include epididymitis. The most common cause of epididymitis, it's chlamydia nowadays. So, but recently we discussed about neisseria gonorrhea. So, but chlamydia is also nowadays it's getting the most common type, most common cause of epididymitis. And Reiter syndrome. Reiter syndrome. So we will discuss it. So you will discuss the internal diseases, so because it includes the arthritis, urethritis, and conjunctivitis. So inflammation of joints, inflammation of urethra, and inflammation of conjunctiva of eye. Okay. So in females, in women, it leads to scarring of fallopian tubes, pelvic inflammatory disease, pelvic pain, and infertility. And also here I would add miscarriages. So because even if fertilization happened, but it fixes and then discharges, it can be discharged and miscarried during the time period. Okay. So with gonorrhea, detecting chlamydia trachomatis in men can be done both through urethral swab and NADS. Yeah. So it's better and now more preferable method for checking for chlamydia is NAD. So it's PCR. NAD is PCR. It's just urethral swab or first portion of urine, and we send it to NAD reaction, and then we identify DNA of this bacteria because they're impossible to be seen in a routine examination. Treatment. So what is the treatment of chlamydia trachomatis? Chlamydia trachomatis, as I said, it's a little more complex disorder. It's intracellular parasite, so which really living inside the cells only, and it should be treated with macrolides because of very good penetration into the cell membrane, through the cell membrane, and doxycycline 100 milligrams orally twice daily for 7 days. So doxycycline is a tetracycline row of antibiotics. Of course, it's prohibited in pregnancies. So, but here we're talking about males. So, and alternative regimens include erythromycin base 500 milligrams or erythromycin ethylsuccinate 800 milligrams. So also for 4 times a day for 7 days. It's American guideline again. Levofloxacin 500 milligrams orally once daily for 7 days. Ofloxacin 300 milligrams orally twice a day for 7 days. Of course, you should ask your patients to abstain from intercourse at least for 7 days. But I'd recommend you to recommend abstain from sex for 1 month. Actually forever use condom. Concurrent testing for gonorrhea, HIV, and syphilis should be performed with any chlamydia diagnosis. So that's why if your patient is positive for this, so it's better to be checked for other infections. Test of cure is not advised for persons completing the advised treatment regimens. So 3 months retest is recommended. So same as in gonorrhea. So 3 month retest. But you should also say to patient that he should send sexual partners to investigation too. So because they also possibly are infected. Okay. And they should be made the presumptive treatment, so which is much less severe. Mycoplasma genitalium. Mycoplasma genitalium is first identified in early 80s. So previously, so why we didn't identify it? So because it can be stained with the gram stain. It's impossible to stain with gram stains. That's why we observed it only when we evolve our microscopic techniques. And actually it's claimed that 15% to 20% of non-gonococcal urethritis cases of urethritis are caused by Mycoplasma genitalium, and 20 to 25% of non-chlamydial non-gonococcal urethritis and 30% of persistent or recurrent urethritis cases. So if your patient used to suffer with chronic urethritis, so it might be related to mycoplasma. So why can't we just make a test for mycoplasma? So we'll talk about it later. Oral genital transmission is less likely given, but still we have a chances to transmit this infection, mycoplasma genitalium, by oropharynx. So that's why don't also same as in gonorrhea, you should abstain from oral sex too, not only against casual sexual contact. So cultures of mycoplasma genitalium can take up to 6 months, so that's why it's a useless thing to do, so to grow up this mycoplasma genitalium. So mycoplasma genitalium lacks a cell wall, cannot be gram stained, as I said before. NATS identifying so PCR, yeah, NATS is PCR. Mycoplasma genitalium, specific nucleic acid, are not only clinically useful method for diagnosis, so that's not only are the only clinical useful methods for diagnosis, but still it's not proved by FDA. So I don't know why, but they claim might be it's not approved. So might be it's useless analysis, but we use it. We use it in Kyrgyzstan, and it's pretty closely related to clinical picture of the patient. That's why we use it and we rely on this test. But FDA, Food and Drug Administration in USA, so it has not approved it yet, and we claim that it's mycoplasma infection. So only if we have recurrent and persistent urethritis with a negative test for gonorrhea and chlamydia. Treatment. So treatment of mycoplasma is also antimicrobial resistance. Antimicrobial because and as well it has no cell wall, so it's useless to use penicillin role and cephalosporin role of antibiotics, because the main point of action of these antibiotics is a cell wall. So that's why we first line treatment is doxycycline. So that's the best treatment against it, and but here they claim it's a 31% median cure rate. Currently, CDS recommend a single dose of 1 gram of azithromycin. So azithromycin is like macrolide, so it's also can cure it. So it's a USA recommendation, but they say 31% cure rate. But doxycycline, I never encountered with doxycycline resistance to mycoplasma. Might be population difference. Might be because some other reason, like I don't know. CDC recommends a single dose of 1 gram of azithromycin. Historically, regimen had a median cure rate of 85%. However, this has dropped to 40% in a recent study. So, what happened might be due to reinfection, might be due to process of reinfection, and you have to talk to your patient about regimen. Because of the treatment failures associated with the single dose azithromycin regimen, and longer course of azithromycin was considered. So nowadays it's 500 milligrams initial dose, followed by 250 milligrams daily for 4 days. So CDC still recommends a single 1 gram azithromycin dose for first line therapy. European guidelines differ in treatment recommendations. So treatment failures should then receive moxifloxacin daily 7, 10 or 14 days, and it has 100% cure rates. Moxifloxacin is fluoroquinolones. So while we reach this point, I want to suggest you another study which I had before. So that's all microbial caused prostatitis. So, and very closely related to this infection. If mycoplasma and chlamydia trachomatis and even ureaplasma ureolyticum are not treated, so later in most of cases, so we don't have studies, but very commonly it causes a prostatitis, chronic prostatitis, very irritable for males, and it's a chronic pelvic pain syndrome. It's named. In one study, which I recently read, so they said that as longer antibiotic treatment you give to patient, as better result of treatment. Doesn't matter which so it matters, yeah, but so by one of these protocols, if you give a longer term, so as longer you give, so as more effective it is. So pretty obvious result, but you see here you see that in protocols they use single dose azithromycin. This is what you should prescribe by protocol. Because why protocols are made? So first of all, your government and our government provide these protocols to with economic reasons too. So because in 95, if it's effective in 95%, so we don't care about this 5%. We care to reduce the spends of this 95% of patients. But this 5% will suffer with chronic prostatitis later. Yeah. So that's why nowadays in urological practice, so we used to provide the long-term treatment against this urethritis, because we suspect that might be there is prostatitis already present, and just to prevent prostatitis in these patients, we provide a more severe treatment with 2 weeks, might be sometimes till 1 month of antibiotic treatment. So it's not in protocol, but just suggestion and what we discuss in urological discussions worldwide. Trichomonas vaginalis. Trichomonas vaginalis, it's a exclusion. It's a diagnosis of exclusion. We also check for this. It's Trichomonas vaginalis. It's a flagellated parasite. It infects predominantly urethra in men, and in women it affects the vaginal and vulvar area. Geographically it's different. In Kyrgyzstan it's very common. I guess in tropic countries it's also very common. So like in Pakistan, India, pretty common. So not FDA approved for use in males, and so better to make a wet mounts of cultures for diagnosis. So because they are visible with the microscopy. So what's the reason to use NAT method? So when it's not so sensitive. So that's why I recommend you to use just wet mounts cultures. The low prevalence of Trichomonas vaginalis in non-gonococcal urethritis does not warrant using these tests in initial workup. Also, they should be considered for male sexual partners to women with trichomoniasis and for other male populations in high prevalence areas of the country. The recommended treatment. So you see, it's they claim it's a very rare disorder, but in Kyrgyzstan it's very common. So that's why you should check epidemiology of Trichomonas vaginalis in your location. If it's very high, so yeah, it's better to make it routinely. If it's low, so you don't have to send a patient for this test. So recommended treatment for Trichomonas vaginalis is metronidazole 2 grams orally once, or tinidazole 2 grams orally once. So you see, they are not antibiotics, they are antiparasitic drugs. Yeah. And here also written that it should be used once, but it's better to treat it for longer term, so at least for 5 days. So just we talk about it in our community. Complication of urethritis in males. So epididymitis. So I said in chlamydia and gonorrhea. So it's very common. Epididymitis are present. So more common now it's chlamydia infection, and even in urethritis it's also very common. Prostatitis. So prostatitis, as I said, in all these cases we discussed before, all of these sexually transmitted diseases, prostatitis is very common. So especially chronic prostatitis. But actually, yeah, and also we have acute prostatitis. So, but acute prostatitis is usually not related to STDs. So only in case of necessary gonorrhea. So it's acute, but chronic, so can be caused both by gonorrheal, so gonococcal urethritis and non-gonococcal urethritis. So that so about prostatitis we will discuss more details in further topics. Reiter syndrome. So what is urethral syndrome? We discussed in chlamydia topic. Male infertility. Usually, if inflammation causes epididymitis, so where epididymis, so epididymis is the main place where maturing of sperm cells happening. So that's why male infertility is very common in these infections after epididymitis. So that's what you should scare your patient. Yeah. So about this. Abstain from the infections. Erectile dysfunction. That's second thing, so which frighten every male from the sex without condom. Yeah, so erectile dysfunction is very commonly present, especially due to prostatitis. Chronic prostatitis, which decreases the functional activity of prostate, and erectile dysfunction is very commonly present. And urethral stricture. If gonorrhea is not treated, so when in the first time, so when a patient didn't came to doctor or didn't follow advices of doctor to treat this gonorrhea, very commonly it comes to chronic inflammation, and as any chronic inflammation, as I said in every class, yeah, so chronic inflammation causes alternative activation of macrophages, which causes the formation of activation of fibroblasts to produce collagen fibers. So it leads to formation of adhesions and even growth of connective tissue in submucosal line, and also in lamina propria, and it leads to constriction of urinary urethra outflow. So and this condition is named as urethral stricture. It requires a plastic surgery. It requires a plastic urethral surgery. Okay, that's it. Thank you for attention. See you in the next video. Goodbye.